So good morning, everyone. I just want to thank you for taking this chance to be part of this presentation for today. My name is George Derrick, and I will be your moderator for today. So the main presenter is Peter Simiu. Peter Simiu has a Bachelor in Medical Laboratory Science and he has majored in the microbiology department. So you notice that this is the second time we are having this microscopy, malaria microscopy CME, and we hope the session will be very interactive, and we hope that you'll get something out of this presentation. So very fast, let me just give Peter the chance to take us through the presentation.
Good morning, everyone. As George has said, this is the second time we are having this presentation, but we will expect more interaction in this section so that we can learn more about malaria microscopy. So let's go ahead, see the overview of what we are going to learn today. So today we are going to see microscopy techniques and quality assurance practices. We are going to have a look at staining techniques. We are going to be able to differentiate different malaria species and different stages. We are going to have interactive case studies and quizzes so that we can learn more. And then we are going to see how we do quantification and reporting of malaria. And then we are going to see how accuracy and efficiency of malaria diagnosis impacts patient management. So let's begin with this quick case study where a 32-year-old woman presented with fever, fatigue. That is 2 weeks after being treated for malaria based on a positive RDT at a local clinic. Although this patient had completed artemether lumefantrine treatment, her symptoms recurred. This is after 2 weeks. So after 2 weeks, a microscopy was done. It revealed Plasmodium ovale. So this explains the relapse of the fever and the fatigue. So the patient had to be treated with a combination of drugs that targets both liver and the bloodstream infection to prevent another relapse. So this clearly shows the importance of microscopy over other methods like RDT, although RDTs are somehow more sensitive, but microscopy gives you a clear picture of what is going on in the patient, because it will tell you that this is a species, like it is a falciparum, it is malaria, it is ovale, so that proper treatment and management can be done to this patient. So if microscopy had been done to this patient earlier enough, it would have been noticed that it was Plasmodium ovale, and the treatment would have been different, and that the patient would not have gone to the hospital again for the second time for treatment of the stem. So quickly, what is microscopy? Microscopy is a gold standard technique for definitive diagnosis of malaria. So it is just a visual examination of a stained film under a microscope. And microscopy answers 3 questions, where is there a parasite? And what is the identity of this parasite? And what is the quantity of this parasite in the bloodstream? So we will look at a brief history of malaria. So malaria dates back to 2700 BCE. So where we had early written symptoms of like fever, chills, which were recorded in ancient China. And then we have this period of 4th century BCE, where a Greek physician called Hippocrates. So Hippocrates provided the first details of clinical description of malaria. He also linked the disease to swampy areas and describe the characteristics of periodic fevers of different species of malaria. So these fevers were three, where we had the quotian, tertian, and condition. So these fevers are characteristics of different species. So after 24 hours or continuous fevers or asynchronic fevers are experienced in falciparum infection and somehow P. knowlesi. And then we have fevers that are experienced after 48 hours. These ones are most commonly characteristics of P. vivax, P. malariae, and sometimes P. falciparum. So these fevers happens when the parasites are now released from the liver into the bloodstream. That is when now someone experiences these fevers. And then after 72 hours, we have the P. malariae. Then in 1880, we have a French surgeon called Charles Louis Alphonse, who was working in Algeria. So he observed the first trophozoites parasite in human blood under a microscope, and he correctly identified it as a protozoan parasite. And then 10 years later, we have a Russian named Dmitry Romanovsky, who developed the germ sustain using methylene blue and eosin. And then in 1900s, early 1900s, major human species were able to be identified and described using a microscope. And then we have now advanced methods for quick identification of malaria and more sensitive methods like PCR, qPCR, and LAMP. So this is just a brief history of malaria, general malaria, and how microscopy came about. So to understand well what we are looking at in a blood smear, we need to also understand the life cycle of malaria. So malaria life cycle is divided into three stages, where we have the sporogenic cycle. This happens inside the female Anopheles mosquito. And then we have the exoerythrocytic cycle, which happens inside the human liver. And then we have the erythrocytic cycle. This is in now human peripheral blood. So malaria microscopy basically detects malaria parasites that are inside the human blood, that is the peripheral blood, and in the third cycle, which is the erythrocytic cycle. So you can see the pictogram of the erythrocytic cycle, where we can see immature trophozoites. These are the ring stages. The ring stages can be seen in blood. You can also find mature trophozoites in blood. The same, you can see gametocytes, you can see schizons in blood. So the pictogram shows all the parasitic stages that can be seen in a blood film. So let's quickly look at slide preparation. So after collecting your blood, you need to make a smear that is thick and a thin film. So before you make your smear, you need to label the slide with the required patient identification details. And then you have to make sure that your slide is clean and the slide has no cracks or anything else. So you place 6 microliters of blood for the thick film and 2 to 3 microliters of blood for the thin film. Then you need to use a spreader at an angle of 30 to 45 degrees to spread the blood for the thin film, and then use the bevel corner of the spreader to spread the blood for the thick film to form an evenly circle covering around 12 millimeters in diameter. So the films are dried on a flat surface and ensure that they are protected from dust and insects. And then the thin film is fixed using absolute methanol for a few seconds. And then you let the slide air dry. And then the slide is air dried while it is sitting vertically with the thin film facing downwards. So this will prevent the methanol from fixing the thick film. Remember, the thick film should not be fixed. It's only the thin film that needs to be fixed with methanol.
Very fast, we have a quiz here, our very first quiz. Those who had attended the last session, you have the privilege of getting the answer correct. So you can use the chat box just to answer this quiz. The question is, which one of the following stain is not used for staining malaria parasite? Choice number A, we have Gemsa. B, we have field stain. C, we have methylene blue. And D, we have Wright's or Leishman stain. Then E, we have acridine orange. So I'm seeing Lucy Kim choice C, methylene blue. That is the correct answer. Thank you everyone for participating. We will look at E, that was very much contested. You will see it as we proceed. Choice number E, acridine orange, is used in the QBC method, and it is actually a stain for staining malaria parasites. So Peter, you can proceed. Thank you for taking the chance to answer.
Everyone has gotten the correct answer in this quiz. So staining for malaria microscopy, there are different types of stain that are used for malaria microscopy, which we are going to look at them. So what is staining? Staining is the art of making the invisible visible. And then there are different types of stain used in malaria microscopy. The choice of stain used in malaria microscopy is dependent on the laboratory standard procedures and the requirements. Here are the number of stains that we use for malaria microscopy. We have the Gemsa stain. The Gemsa stain is the gold standard stain. It is used for routine diagnosis. It gives good species identification, and it also gives good quantification. This stain gives best detail and contrast at a pH of 7.2. So it is best to ensure that your Gemsa stain is buffered at a pH of 7.2. The only key limitation of this stain is it's time consuming. It takes around 10 minutes to do the Gemsa staining. Then we have the other stain is the rapid field stain. So this stain is best for field screening. It gives rapid results. It is fast. It takes 1 to 2 minutes to stain, but it has a key limitation because it does not give good detail of stippling. For example, the Schnupfter dots cannot be well seen when you are doing your malaria staining using the field stain. The third stain that we use for malaria staining is the Wright's or Leishman stain. This stain is used for general hematology, and it is normally readily available, but it is unsuitable for thick films because this stain is it has a fixative inside, so you cannot use it for thick films. It is only best for thin films. If you use the stain for thick film, you will end up fixing the thick film, which does not need to be fixed when doing malaria microscopy. Then we have the acridine orange. It has high throughput for screening. It is fast and for sensitive detection. Although it gives poor species identification, it has a tendency of high false positive and requires a fluorescent microscope. So we will have a look at how the acridine orange stain looks under a fluorescent microscope and how the procedure is done. So let's have a look at how we review our slides. That is after staining the slides, how are we going to review the slides to ensure that we can declare a slide either positive or negative for malaria parasite. So here's a case where a laboratory technologist reviewed a thin blood smear from a febrile patient by randomly moving the slide under a microscope. After a quick scan, the report was no malaria parasite seen. But later, the smear was re-examined systematically using one of the methods for smear review called the meander method, and multiple Plasmodium falciparum parasites were detected. So you can see there is a contrasting results between the two smear reviews. The first one, it was random and it was negative. And the second one, the review was systematic and a few parasites were able to be seen. So we have different ways of slide review. And a systematic slide review ensures that the whole smear covered and reduces the observer error or bias. So there are quite a number of techniques. We have listed 4 of them, where we have the serpentine or the meander method. This is the zigzag pattern review of a smear, where you review a smear in a zigzag manner. This ensures that the whole smear is covered and you cannot miss a parasite when you review this method. Also, we have the battlement method or the castle battlement pattern. So this is where you review a slide where you move upwards, you move across, and then you review again a slide downwards, then you review it across. Also, this ensures that the whole slide has been covered. And then we have the strip method, where the slide is examined on a long strip from end to end before moving to the next strip. And then we have the track method. It is like reading a book, almost similar to the strip method, where you read the slide line by line. You create virtual lines on a slide, so you ensure that you've covered all the slide or the smear under a microscope. So when you review a slide systematically, it ensures that you have reviewed all the places on a slide. So this one ensures that you have not missed any parasite, even if you declare a slide negative or positive. So let's quickly go to the thick film. So the thick film is considered as a screening tool. And why? Because the thick film is used to rapidly detect the presence of parasite. It provides the basis for quantification. On the thick film, the diseases are light, so the morphology is not well preserved. So what are we looking for on a thick film? On a thick film, we are looking for the parasitic forms. The parasitic forms, we are looking for the chromatin, the DNA, which is stained red-purple. We are looking also for the cytoplasm, which is stained blue. We are also looking for specific structures. We are looking for trophozoites. We are looking for the ring forms. They appear as blue cytoplasmic ring form with chromatin dots. They are often shrunken or deformed. They are deformed because the thick film is not fixed, so the morphology is not clearly kept. We have the gametocytes, and then the gametocytes for P. falciparum are often seen here on a thick film. They are crescent shaped, so when you are looking for a thick film, you are not only looking for the ring forms, you are looking for also for gametocytes, you are also looking for schizons, you are also looking for the pigments. So the schizons are clusters of mitozoids. They look like a bunch of grapes. There are also diagnostic characteristics of falciparum. So all these 4 structures are diagnostic. If you see either of them on a thick film, the slide is positive for malaria.
So we have another question, our second question here. Identify the stage and the species of the parasite. For slide A, please just answer it that way. So slide A, we have P falciparum trophozoite. B, we have P falciparum P malariae trophozoite. Then C, we have P vivax trophozoite. Then for slide B, we have P falciparum trophozoite. Then B, we have P malariae trophozoite. Then C, we have P vivax trophozoite. Please use the comment section to answer the question so that we can proceed. It's quite complex. So, okay, so very fast, we will end it at that. So for slide A, the correct answer was P. falciparum trophozoite. Then for slide B, the correct answer is P. vivax trophozoite. Thank you everyone for attempting to answer that. That was quite a good interaction, and we appreciate your participation.
Let us look at the slides again. You can look at slide A. This is classical P. falciparum trophozoites. You can see multiple rings in an RBC. You can see the rings are small, they are delicate. You can see one of the rings has double chromatin dots. So this is a classical P. falciparum trophozoid infection. When we go to slide B, we can see there are only two parasites on the slide, and we can see we have only one parasite per RBC. You can see the morphology of the size of the RBC is also enlarged. So this is a classical presentation of P. vivax trophozoite. It alters the size of an RBC, and you won't find multiple rings inside one RBC. So they only affect one parasite in an RBC. So thank you everyone. All the answers were correct. So when we look at these images, we have the images are of a thick film. So on the top left, these are ring forms of or parasitic forms of P. falciparum. On the top right, we can see a poorly stained thick film where we can see trophozoites but can easily be missed out as artifacts. So it is very good to ensure that your slide is very well stained. On the bottom right, we can see a number of different types of trophozoites. We can see rings with double chromatin. We can see one chromatin. We can see rings with very coarse cytoplasm, classical presentation of P. malariae. On the bottom right, that is image C, we can see grape-like forms. These are schizons. We can see a gametocyte here. So this slide basically shows what we normally see on a thick film. So here is another presentation of a thick film for different trophozoites. So we can see on the left, we have P. vivax trophozoites. We can see they are large, they are amoeboid, they have amoeboid cytoplasm. We can see some pigments, though they cannot be clearly seen, but they are normally yellow to brown pigments. And then we have one or two prominent chromatin dots. So we can see on the images, they are quite amoeboid. You can see even the shape of the parasite is not clearly seen, but it is a bit amoeboid. And then we can see the chromatin dots. They can be large. And then we have the pigments on the parasites. And then on the right side, we have the ovale. So the ovale cytoplasm appears quite dense. You can differentiate the two because the other one, the cytoplasm is quite not dense, but here the cytoplasm is dense. Then it is well developed, one or more prominent, well-defined chromatin dots within a tropozoid, and then they are compact to irregular in shape. So here we have P. malariae. So the P. malariae, they are always compact, dark brown with one or more large chromatin dots. So the key characteristics of these parasites is they are solid, dark, and big. They are solid, dark, pigmented, and compact in form. So when you go back to the previous slide, you can easily differentiate between P. vivax and P. malariae trophozoites. And then at the bottom here, we have gametocytes. You can see the crescent shape or the banana shape. These gametocytes are typical for Plasmodium falciparum. These are the forms that are responsible for transmission to mosquitoes. So the mosquitoes picks up these gametocytes, and the gametocytes are also diagnostic. So when you find gametocytes on a blood film, don't ignore them. You need to report them so that the patient can get the correct treatment. So let us look at a thin film. So a thin film is used to properly identify the species, and also it is used for quantification. So the morphology of both the parasite and the infected RBCs are preserved well by fixation. Remember, in the thick film, the morphology is not well preserved because the thick film is not fixed. But here, we can very clearly see a well-preserved RBC and a well-preserved parasitic form. So a thin film provides a good identification tool of the species and also good for quantification. So what are we looking for when we review a thin film? We are looking for an infected RBC. So in this infected RBC, what are we looking for? Is the size enlarged or has the RBC maintained its normal size? If the size is enlarged, this is a classical P. vivax. It's also classical P. ovale. They tend to tamper with the morphology or the size of an RBC. If the size is normal, this is classical for P. falciparum or P. malariae. They don't tamper with the size of RBC. When we look at the shape, if the shape distorted, so P. ovale tends to cause fimbriation of an RBC, or they tend to make an RBC form an oval shape. So also just checking at the shape or the size of an RBC, it can also tell you which type of a parasite are we looking at. And then another thing that we are looking for is the stippling. Stipplings are visible dots in the RBC. So we have the Schnupfner dots. Schnupfner dots are seen in P. vivax. They are always pink to red dots seen in P. vivax. We have the Yames dots. These are found in P. ovale. And then we have the Mura clefts. They are always large, coarse, reddish dots, and they are seen in P. falciparum. And then lastly, we have the Siemens dots. They are rarely seen, but if you see them, they are fine dots, and they are presentation of P. malariae. So here is a pictogram of a thin film. You can see the thin film is very well prepared. The RBCs are single, they are not aggregated or clumped together. So this also tells us that when we are preparing a thin film, we need to make sure that the thin film is prepared very well so that it can give us a good view of the parasite and a good view of the RBC shape and size. So when we look at this, we can see the delicate forms of P. falciparum. You can see the multiple rings inside an RBC. We can see double chromatin dots in a parasite. So this is a presentation of P. falciparum. And then also P. falciparum, they tend to be found on the edges of an RBC. Even if you can look at the images and you can see some of them are found on the edges of an RBC. Then here we have P. ovale. So when you look at the images and when you look at the previous image here, you can see the difference. The difference here is that this RBC here, the top right, the top left RBC is oval in shape. Even the bottom one is oval in shape. The top right is fimbriated. You can clearly see those fimbration at the end of that RBC. You can see one parasite inside a cell. On the other side, we saw multiple parasites inside the cell. And then we can also see the James dots that is on the bottom image. You can see there are quite a number of dots inside the RBC. So when you're looking at a thin film, there are quite a number of things you need to look for. You can not only look for the parasite, but you can also look at the key characteristics or other key features that can tell you which type of a parasite that we are looking at. So here we have an image showing P. vivax. You can see image number 4, image number 1, 2, 4, and 5. These images are photrovozoids. You can see they are amoeboid, thick cytoplasm. You can see the Stoffner dots. You can see the size of the RBCs is large compared to the other RBCs that are uninfected. And then on the top right, you can see a gametocyte on the same image. And then the gametocyte is either round or oval, and then it takes up the entire RBC. And then you can also see dark pigments inside that gametocyte. So we can also see the key features of P. vivax here. We can see the RBC is enlarged. We can see the Stoffner dots. We can also see the thick amoeboid form of this parasite here. Then Plasmodium malariae. We can look at the band form. We have two images here. The top image, at the center, we can see two parasites. One is the ring form, and the other one is the band form. So you can see the band form, it's like it crosses in the middle of an RBC. That is the classical presentation of a Plasmodium malariae. And then the bottom image also shows a P. malariae, but in a bird's eye view. It is a ring-like cytoplasm with a chromatin dot, that is the parasite's nucleus position at the center, giving the resemblance of a bird's eye. So when you look at the bottom image, you might think this is a bird's eye. If you compare it to a bird's eye, that is it looks almost similar. So Plasmodium malariae can be seen in two forms. you can see a band form, and you can also see the bird's eye view. That is how Plasmodium malariae presents itself on a thin film. Then we have P. knowlesi. P. knowlesi, this is mostly zoonotic, and then it resembles both P. falciparum and P. malariae. So it resembles them in such a way that the early rings of this knowlesi, they resemble or mimic P. falciparum. So you might find them at the edges of an RBC, and then you might find there are also multiple inside an RBC. And then the schizons are up to 16 merozoites, and then they rapidly replicate in a cycle. So P. knowlesi can be easily be confused with either P. malariae or P. falciparum. So it needs to be very keenly identified. Let us look at another feature that we look when we are reviewing a thin smear. We have the gametocytes. So these are gametocytes of a P. falciparum. You can see it is a crescent or banana shape, but also on this slide, you can see an RBC that is infected with the rings or the trophozoites. So here we can see two stages of a parasite. We can see the gametocytic stage, and you can also see the ring stages of this. Then we can have a look at the Plasmodium malariae gametocytes. They are round to oval and almost fills an entire RBC. Remember, the P. malariae gametocytes, they are rarely found on a blood film. Then they are characterized by the presence of a scattered brown pigment. So you can see here we have only one, and it has filled an entire RBC. Then you can see some brownish pigments inside that gametocyte. Then we have ovale gametocytes. They develop in the liver and are taken up by mosquitoes for transmission. They are round to oval and fill much of an infected RBC cell. So P. vivax also exhibits almost similar characteristics to P. ovale. We saw the P. vivax gametocytes earlier in the slides before. So another thing that we can look for when we are reviewing a slide are these pigments. They can easily or quickly help you identify or differentiate different types of a parasite. So they are always brown to black pigments. So for P. malariae, you can find dark coarse pigments, and then we have the fine and golden brown pigments. They are seen in Plasmodium vivax. Schizons, they are diagnostic, they are multinucleated, and they are the asexual stage of Plasmodium species. They are found within a host cell, either in the liver or they can also find inside RBC. They develop through schizogony process of repeated nuclear or DNA replication. So they replicate inside an RBC or inside the liver. And then when the RBC or the mature schizont ruptures, it releases the small merozoites. Those are the daughter cells. So the daughter cells are the ones that are released into the bloodstream, and then they transform into now the ring forms. So different types of Plasmodium falciparum are present with different types of schizons. So these schizons, they are often, the merozoites inside the schizons are often help indicate which type of parasites are we looking at. So when you find a schizont, you can count the number of merozoites. So if you have 12 to 24, this is and then the RBC is enlarged. This is a P. vivax. And then we have 8 to 12, and then they are in a rosette pattern. This is a P. malariae. And then P. falciparum, rarely seen in blood film. They are 4 to 16. And then you can get 6 to 14, that is for P. ovale schizons. So all the characteristics or the features that we have seen here, they are diagnostic. If you find them in a blood film, you need to report them as positive for malaria, and then you need to do the identification. Let us have a look at fluorescent microscopy. So fluorescent microscopy, this is where we use the acridine orange to stain peripheral blood for malaria species identification. And the method used is called the quantitative Buffy-Coat for malaria test. This is where we have a capillary tube, and this capillary tube is coated, is coated with a stain, and this stain is acridine orange. And also inside the capillary tube, we have a small anticoagulant. So a small blood sample is placed inside the tube. The tube is centrifuged. A special centrifuge is used to centrifuge this tube to concentrate malaria parasite. And then the sample is examined using a fluorescent microscope. This is after centrifuging. So the parasites are stained with acridine orange. So the acridine orange stains the DNA, the the this the cytoplasm and the chromatin of a parasite. So, and then also we have a dark background. So when the parasite is stained, it fluoresces, it produces a bright color against the dark background, which is produced by the RBCs. So the RBCs, they don't pick up this stain, but the parasite picks up the stain. So when you observe this sample under a microscope, you will be able to see the parasites, which are brightly colored, against a dark background, which is provided by RBCs. So this method is rapid, and it provides high degree of sensitivity for detecting parasite. It is effective for screening in endemic areas. So here is a pictorial presentation of a QBC. On the left, you can see how the tube looks like. It is a small thin tube. After centrifugation, it separates the blood into different components. The upper part is the plasma layer, and then we have the next part is the gametocytes can be found on the lower part, and the platelets layer. We can also find the schizons on the layer number 3, number 2, and then mature trophozoites are found on the layer number 3. And then the ring forms or immature trophozoites are found on the 4th layer. And this is where the RBCs provide the dark background for reviewing of these parasites. So on the right image, you can see a dark background. You can see stained parasites. You can see the brightly stained parasites. You can see the chromatin dots are stained, and you can see the cytoplasm is not brightly stained, but it can easily be seen. So these acridine orange stains has a disadvantage because it can, if you find a patient has a lot of immature RBCs, the stain might end up staining them, or if we have platelets, a lot of them, the stain might stain them, and you might end up giving false positive results. So you need to be very careful. You need to know the morphology or the shape of a parasite to be able to correctly identify it. Let us look at quantification of malaria parasite. So a thick film you can be used to quantify malaria parasites, where we count the parasites against the number of WBCs. So when Quantifying using a thick film, you need to count up to 200 WBCs, concurrently counting the number of parasites. So the formula is to get parasites per microliter of blood, you need to count the number of parasites against 200 WBCs, multiply the number by actual WBCs. This is if you have the actual number of WBCs from a CBC report. Or the alternative method, this is by using the assumed WBC count, and this method is WHO approved, that is WHO approved. This is where you count the number of parasites against 200 RBCs, and then you multiply by 8,000 WBCs to get the number of parasites per microliter of blood. When using a thin film gives the parasite density as a percentage of the number of RBC cells that are infected. So you need to ensure that you are counting the number of parasites on a monolayer thin film. So thin film preparation and staining is also key here. So you need to count the number of infected RBCs. And in the same area, count the total number of RBCs. Recommended number is up to 2,000 RBCs. So the formula is to get the percentage parasitemia, the total number of infected RBCs over total number of RBCs counted, that is 2,000, and then you multiply by 100. This one gives you the parasite density as a percentage. To get the parasite density per microliter of blood, you multiply the parasitemia times the patient's RBC count from a complete hemogram result. So we have a study here where an 8-year-old girl presents with fever and chills for 24 hours. A CBC and malaria test is requested. The blood smear reveals small, delicate rings with multiple parasites infecting a single RBC. On the thin film, 5 parasites are counted per 2,000 RBCs. The CBC reports the total RBC count as 3.2 times 10 raised to power 6 per microliter. Based on this case report, the most likely species is Plasmodium falciparum. So the delicate rings, multiple parasites infecting an RBC, and then they are small in size. This is a typical Plasmodium falciparum. So percentage parasitemia, you need to take the 5 number of RBCs count, parasitized RBCs over the total number of RBCs counted, that is 2,000, to get percentage parasitemia as 0.25%. And then when you are reporting, you need to report both the species and you need to give the parasite density. This one helps in patient management. So how does microscopy help us in patient management? So parasite density helps us classify the disease severity and it guides on therapy. So it is very key to give the quantity of the parasites inside the blood. And then repeat microscopy is done when there is still clinical suspicion while the results turn out negative. So you need to do repeat microscopy after a while. Around recommended is around 8 to 12 hours. So you need to do repeat microscopy. And then you can correlate RDT results, not only RDT. If you are able to do PCR or other methods, you can correlate them with microscopy for quality and accuracy. Then remember, microscopy remains vital in monitoring treatment response. What are some of the quality assurance that we do in malaria microscopy? So you can use internal quality controls. For example, verifying the pH stain. Remember for GEMSA, the recommended pH that gives good contrast is a pH of 7.2. You can use control smears, that is a positive and negative control smears while you are doing your patient smears. You can also do rechecking of slides or getting a second review. And then we also have other methods like external quality assessment and interlab comparison programs. This one really helps you in competency of staff, and it really helps in checking how you can accurately identify and quantify malaria parasites. And then we have the annual competency or annual proficiency testing and peer reviews. And then documentation of documentation and corrective actions for discrepancies in malaria identification programs. So we have the 5 golden rules for malaria microscopy. So rule number 1, examine up to 200 WBCs or 2000 RBCs before declaring a smear negative. So ensure you have examined a smear in totality before declaring it negative. And then maintain fresh, properly buffered Gemsa stain at a pH of 7.2. And then prepare films with optimal thickness and use clean slides. Identify the parasite species. Do not assume. The species are helpful in managing the patient. And then always record the parasite density and the stage. This one is also very helpful in managing the patient. So what are some of the common pitfalls that we encounter in malaria microscopy? So pre-analytical forms, we have in the thick film, there might be too thick cracks or thin, which can cause low sensitivity. So thick cracks affect the staining and really create a lot of artifacts. And the artifacts can also be misidentified as positive for malaria. And then a thin film ensure no feathered edge. The cell trails from don't use a dirty spreader because a dirty spreader will create the feathered edges. And then ensure adequate drying of your smears. Some of the analytical errors encountered are incorrect Gemsa pH, then unfiltered stains with a lot of precipitate and inadequate washing of the slides. Another thing is misidentification. So one of the reasons we are doing this CME is to ensure that we correctly identify and quantify malaria parasites. So misidentification will lead to mismanagement of the patients. And then some of the post-analytical errors are failing to report the species and the parasite density. So the speciation and parasite density are very important in patient management. So thank you very much for taking your time and listening to the presentation. So if you have any questions, any comments, or any additional comments, kindly share them in the chat box.
Thank you, Peter, for that wonderful presentation. It was so much interactive and educative. We have the first question here. Why, by Evelyn? Evelyn is asking, why is it important to mention gametocytes to the clinicians? So, I can tackle that. Okay, so it is very important to mention gametocytes to the clinician because the very first reason is number one, is that it means that malaria is there. It means that that person has malaria. So failing to mentioning it is not okay because clinicians need that information to know that this person has malaria. But now when we look at gametocytes are the sexual stage of malaria. So the sexual stage of malaria, it means that this person is very much infective and is able to transmit that parasite to the community. So it is also important to mention the gametocyte stage of malaria to the clinician for them to know how to curb the disease, and also for the clinicians to know how to manage the community, because at the end of the day, we want to prevent this infection from proceeding. Then we also have another question here from Hassan Juma. Can we truly identify species in QBC method? The answer is no. We cannot identify species in QBC method. QBC is a rapid screening method, and after we identify the malaria in a QBC method, then we need to switch to the slide method, whereby we can be able to do species. Peter mentioned that species is best identified using the thin film. So after we do the QBC, we switch to the thin film for us to know the species identification. Then Hassan is also asking, kindly expound on the monolayer thin film. So the monolayer thin film is just the area of the thin smear where the red cells form a single layer. When we do the thin film, there's the upper part where there's a single layer. So just touching but not overlapping. The cells are touching and they are not overlapping. It is the best area for identifying Plasmodium species because cells and parasites morphology are well preserved in this area. Then again, a well-prepared monolayer shows evenly spaced cells and a clear non-feathered edge. So it is at this point whereby we can do the speciation very well, and we can also do the staging quite well. Okay. Somebody is asking to share the presentation. It will be quite hard to share presentation, but I know they're working on something. Then the CPD link, CPD claim form is already in the chat box. Kindly claim your CPD points there. Just click on the link and fill the form. Peter Morocco is saying, thank you, Peter and George. That was a great presentation. We appreciate Peter Morocco. Then thank you for the great presentation from Gerald Kariuki. We appreciate. Then Ngera, to everyone, what do you do when you have negative microscopy results, but the RDT is positive?
So the negative malaria microscopy result and the RDT positive is an indication of malaria, and it is reported as RDT positive and microscopy negative. This is because an RDT is much more sensitive. And remember, an RDT can detect positive for malaria even after the patient has undergone treatment. So a patient might have undergone treatment for around 2, 3, or 4 days. And then when you review a slide, there is no parasite because the parasites are cleared or they are very low that cannot be seen in a slide. But an RDT, since an RDT is highly sensitive, it will detect it as positive. So it is very good or okay to report as RDT positive and microscopy negative.
Thank you, Peter, for that. And the vice versa can also happen, by the way, whereby the RDT is negative and the slide is positive. Depending on the type of kit you are using, some of them do not detect the rare species like the Nolensi, things like that. So the opposite can also happen. Then Martin Kabura is saying Kazi Safi, we appreciate. Then Lucy Madenge is also saying good presentation. Any more questions before we call it a day?
So before we call it a day, it is good to always correlate both RDT and microscopy to ensure that a correct diagnosis is done.
Okay, thank you everyone for taking a chance to attend this presentation. We will end it at that, and we appreciate your time for being with us for the past 1 hour, 20 minutes. We appreciate, and we are always ready to do more of this in case there is a need for presentation. You can log out. We appreciate.